Hello everyone, my name is Tashelle and welcome to The Journey. Okay, so as you can see today we're going to be talking about gastrointestinal system. More specifically, we're going to be talking about GERD. And GERD pretty much stands for Gastroesophageal Reflux Disease, okay? And you're probably saying, what is that? So what it is a backflow of the gastric content or duodenal content, which is in the small intestines, that backflows into the esophagus, okay? Hence the word gastro, right, stomach content in the esophagus, right, there's a reflux of that, okay? So the definition is somewhat in the word, at least for this one, okay? So the causes, why does it happen? Why, right? How can we prevent it? So what it is an incompetent lower esophageal sphincter, right? Or it can be pyloric stenosis or mobility disorder, right? And we have many different mobility disorders, which we're going to go over in a different lecture. But today, more specifically, I want to talk about the esophageal sphincter and the pyloric stenosis, because you get a lot of test questions as far as with GERD in reference of these are the main causes, okay? So with the esophageal sphincter, all right, I have a picture here. So this is my picture showing you exactly what's going on in the GI tract. So the esophagus, I highlighted in green so you know that this is the region of the esophagus. The stomach, again, is in orange, so the area that's in orange is the stomach. The small intestines is in purple, so that's your small intestine. And then the esophageal sphincter, also known as the cardiac sphincter. So if you've recently went and had anatomy or so physiology within the last 5 years, they use the name cardiac sphincter. But I just want to let you know, cardiac sphincter and esophageal sphincter are the same thing, okay? So, and that region is in red, so that is your cardiac or esophageal sphincter here, okay? So, when you have, right, this sphincter opens and closes. That is the responsibility of this sphincter, open and close. So when the food goes down into the stomach, right, the sphincter opens. Once that sphincter opens, the food goes into the stomach. The stomach then breaks down the food. It has another sphincter here called the pyloric sphincter, right, and spits food out into the duodenum, right, which is the first region of the small intestine. The small intestine is made up of 3 different regions. So if you hear the word duodenum or duodenum, we're talking about the small intestines, okay? So just remember it is the first part of the small intestine, and that's going to be in this region here, okay? And then from there, you're going to pass the food. It's going to be absorbed, go into the large intestines. From the large intestines, eventually it'll come out whatever waste product that the body does not want to receive, and then eventually it will go down into the toilet as we know. Okay, so with a person who has GERD, this sphincter doesn't open and close as tight as it should, right? Because you want to prevent gastric content from coming up, right? You open it to let things go in, but you don't want things to come back up. With this sphincter, it's weak. So what happens is it doesn't have a tight seal as it normally would. So some of the gastric content that builds up in here sometimes backflows into the esophagus, which is why you feel sometimes that heartburn feeling, right? Or as well, you have pyloric stenosis, which pyloric stenosis is a narrowing of the pyloric area to the duodenum. So that prevents food from flowing into the small intestine as easy as it should. So what happens is that food, right, starts backing up, right, because it's not flowing at a consistent rate. So it backs up till finally some of the gastric content ends up splurring up into the top, into the esophagus. Okay, so those are your 2 causes of why you will have GERD. Okay, the main 2 causes that they like to use test questions on. So if you guys can remember at least these 2, then you understand, or at least get those questions right when they ask you what are the causes. So now we're going to talk about the clinical manifestations, also known as your signs and symptoms, right, which is your nursing assessment, because that's what you're going to assess as a nurse. So we have pyrosis, which pyrosis is just a fancy word to say heartburn, all right? So next thing you have is epigastric pain, okay? Then you have dyspepsia, which dyspepsia is also known as indigestion. You have nausea and regurgitation. Regurgitation is the same thing as vomit, right? You have pain and difficulty with swallowing, hypersalivation. You have dysphagia or odynophagia, which is pain when swallowing, right? And dysphagia is difficulty swallowing, okay? So this is difficulty and this is painful swallowing. And then you have the esophagitis, which is pretty much inflammation of the esophagus, okay? And as you can see, I wrote here, all these signs mimic signs and symptoms of an MI, which an MI is myocardial infarction, which is also known as your heart attack, okay? So as you can see, there are going to be some testings and things like that was going to rule out this symptom versus this type of symptoms, okay? There are other additional things to figure out what's going on. So a lot of times when you're in the hospital, you hear the doctors give several tests to rule out this, to rule out that, right? Because you want to rule out, okay, is this a heart attack or is this GERD, okay? So these are your signs and symptoms of GERD, so just kind of pay attention that they are going to mimic signs and symptoms of an MI. All right, so now we're going to talk about the diagnostic testing, right? So you're going to do an endoscopy, right, or barium swallow to evaluate the damage to the esophageal mucosa. Okay, and what the barium swallow is just a solution that they have for you to swallow, and what it's going to do is going to light up your insides, or it's almost as if, like, think of it as a highlighter, right? It's going to glow up those areas that the doctors need to see within the GI tract to see exactly what's going on. And you have to drink the whole thing. If any of it is discarded, or you end up regurgitating this thing back up, you have to do the whole thing again. So they're going to give you a new bottle of the barium swallow, and you have to swallow the whole thing. And you have to keep it there for a while. And the thing is, with this, it's hard because you get full. They have different flavors, but you have to keep it down up until the testing. So you can't throw it up before the testing, okay? It has to stay down the whole entire time. Once the testing is done, then you're free to throw it up, do whatever it is that you have to do. All right, but you want to hold it as long as you can for the testing, all right? And endoscopy is pretty much, think of it like anything you see scopy, right, is going to be a scope, right? So that's a camera, a visual angle of within the esophagus, okay? So it's going to go endo, meaning, right, the upper part into the mouth, and it's going to scope the esophagus area, and then you have your barium swallow, which is going to highlight. Next you have is you have ambulatory 12 to 36 hour esophageal pH monitoring, right, that you're going to do to evaluate the degree of the acid reflux. So this is another thing that they like to see, or they like to test with the questions that you get from NCLEX, or just with classes, right? They want to make sure that you know the pH level of different content area within the body. So, you know, your stomach is going to be more acidic, right? And then you have your small intestine, which is going to be more of a alkaline. It can be acidic, but it's going to be above 6, okay? Or right at 6 or above 6, okay? And the esophagus is going to be the same. So when they do this pH level, and they see that you're getting a pH level of something that's supposed to be in the stomach content, that is going to be an indicator that, hey, what you have in your esophagus is gastric content, right? Because based on the pH level and where the pH level is in the body, they can locate exactly what content is in there. The next thing you have is your bilirubin monitoring, which is also known as BiliTac. And what that is, it pretty much measures the bowel reflux patterns that is going on within the body, okay? And as you can see, when I had the drawing before, I also had the liver up on there, and the liver does play a part with the digestive system, mainly the gallbladder, but the gallbladder does spits out bile because that helps to break down the fatty foods that we eat, and that also goes, and when you have a regurgitation of these things, a reflux, right, some of that bile, that content can end up coming up into the esophagus as well. So they will also do that type of monitoring to see if there is any bile measured within the esophagus, okay? And all these are indicators to let you know that, hey, this person has gastric content or duodenal content that is now in the esophagus, okay? And the key thing here that I put here, exposure to bile can cause mucosal damage, okay? And I'll get into that with the different layers on another lecture, letting you know the different layers within the body and which layer gets destroyed and end up causing more complications, more damages, okay? So just remember, bile can cause an erosion of that layer, which is going to cause further complications. So now we're going to talk about nurse interventions for a patient who has GERD, right? So one of the things that you want to change is pretty much what they're eating. So you want to instruct the client to avoid factors that is going to cause a decrease in the esophageal sphincter, right? Or that's going to cause esophageal irritation. So those things could be peppermint, chocolate, coffee, fried or fatty foods, carbonated beverages, which is also known as soda, just in case you guys didn't know, alcohol, smoking, like, tobacco, cigarettes, things like that, and milk. A lot of times people say milk. Yes, milk is very acidic, and with any foods that is going to cause acidic levels and things like that, it is going to increase the stomach content to be more acidic, right? And hence you can have a reflux of that as well. Okay, so these are certain things that you want to stay away from, that you know that's going to irritate the reflux from happening, or is going to lower the pressure, right? Because it's an open closed seal, that esophageal sphincter. So you want to make sure that you're not eating foods, or you're not doing things that is going to irritate and lower or decrease that pressure, okay? Because then that's when you get the backflow. Another thing, right, that you want to let your client know that they should be on a low-fat, high-fiber diet, right, and to avoid eating or drinking 2 hours before bedtime. I know a lot of times we like to get like a midnight snack, or we might like to go out to eat for dinner. Then right after we finish eating for dinner, we just come home, take a shower, and we go to bed, right? And within that time frame, it's less than the 2 hours. Well, when you're laying down, right, and the stomach still has to digest those things, it causes a reflux to happen. So to avoid that, right, you want to make sure you're not eating anything 2 hours before bedtime. All right. Also, wearing tight clothes is another thing. You don't want to be wearing tight clothes. You want to be wearing loose-fitted clothes, and you want to also elevate the head of the bed. So I put here an abbreviation, HOB. If you ever have me write down HOB, or you see me write down HOB, it's head of bed. Okay, and you will see that within the hospital setting as well. You see the nurses write HOB, or the doctor may say HOB 30 degrees, and he's putting it in order. So that just lets you know this means head of bed. Okay, so you want to have the head of bed elevated 6 to 8 inches on blocks. Okay, of course, if you don't have blocks, there's other supplements you can use. You can use pillows or something like that, but try to give it, make it the equivalent of 6 to 8 inches. Okay. Also, you want to avoid the use of anticholinergic medications. Okay. Why? Because it delays the stomach emptying. Okay. Also, NSAIDs. And NSAIDs is pretty much your medication that are your Advil, your ibuprofen, your aspirin, all right? Those type of anti-inflammatory medication, okay? So non-steroidal, anti-inflammatory type of medication that's going to be doing those things, okay? Also, too, other medication that may have acetylates in them, and pretty much anytime you see this word right here, salicylates, okay, that means aspirin, okay, or things that are containing aspirin-like characteristics, okay? Those should be avoided as well, okay? And then you also have prescribed medication. So after you've done all this and you still have the heartburn, right, the epigastric pain that you're feeling, right, you're still experiencing the GERD, the doctor may want to prescribe you some medications. And some medication that you have antacids, and antacids are your neutralizers, right? Your alkaline type substance. So those are your tums, all right? So when you see antacids, think of tums, okay? I guess you can look at the T for antacids, right? The T for tums, all right? You gotta find something to kind of get you guys to remember, because I am going to make another lecture, and it is going to be on these medications, and I'm going to go into the action, side effects, indications, things like that. So at times it's going to get overwhelming, so you got to find those little simple, even silly things to figure out what these medications are doing, okay? I have my H2 blockers, my proton pump inhibitors, also known as PPI. You have your prokinetic medication that could be prescribed, and with those you have a medication by the name of Reglan. Reglan is the trade name. I put the generic name here. And with this medication, you want to be careful, because the side effects causes extrapyramidal side effects, which I will go over that in another lecture. But pretty much these are your neurologic symptoms that you are going to experience, right? You may have the lip smacking and things like that that may go on. Uncontrollable movements or so I'll put down in the description box below more information about the extrapyramidal side effects. So please also check out the description box. I put extra things that I may not always cover on the actual lecture, but I may put it in the description box. So take a look at the description box because it will give you some good, helpful tips, okay? All right, so we're going to continue on with nurse interventions, right? So we were talking about earlier when we talked about the prokinetic type of medication. So one thing that you want to educate your patient about this medication is that if it is prescribed, it is going to accelerate or increase the gastric emptying. Okay, so you just want to let them know, because they may, the food is going to empty out a lot faster, right? And in that process of it's emptying a lot faster, right, the gastric content is not able to back up and cause the reflux. So with that said, they may experience, being more hungry or, whatever side effects that may come with that medication. So you just want to let them know that, hey, this is what the medication is doing and how it's preventing. So again, education and teaching, okay? And then last but not least is surgery. And sometimes you'll see surgery as a last resort. So it's not going to be the first thing that they do right away, right? They're going to try to see what they can do. They can change the eating habits. They educate you, tell you not to eat, all the different things that we talked about 2 hours before bedtime, right? So once everything that you've done before the surgery, right, and it has still failed and it is not working, then they will go ahead and consider surgery, okay? And surgery may be required in extreme cases, right? Like I said, if it is not working, right? And what it is, it involves the fundoplication, right, which is the wrapping portion of the gastric fundus around the sphincter area of the esophagus, all right? So surgery may be performed laparoscopically or open method. And open method just pretty much means a slit right down into that area. They go ahead and perform the surgery, or laparoscopic means that they go through the belly button, and from there they take a scope. They're guided with a scope on a big screen or, a screen where they can see, and from there they'll go ahead and perform this surgery laparoscopically. Of course, laparoscopically is preferred if they can do it, just because it's less invasive, it's faster healing time, less complications, right? But there are times where it's a difficulty surgery. They may not be able to go in laparoscopic, and they may just need to cut open, and that's where you have your the open method, and they may do that surgery as well. All right, so now we're going to go ahead and talk about Barrett's esophagus, okay? And Barrett's esophagus, also known as Barrett's disease, right, is very similar to GERD, but it does have its differences, okay? So it's pretty much a condition in which the lining of the esophageal mucosa is altered, okay? So the lining of the mucosa in the esophagus is going to be altered, okay? And it occurs in association with GERD, all right? So that's the thing. It's not GERD, but it's an association with GERD, all right? So a long-standing untreated GERD may lead to Barrett's esophagus, okay? So like we went over the different treatment plans for the GERD, right? Let's say I wasn't doing any of those things, and I just kept saying, oh, it's just heartburn. I just suffer from heartburn, right? And I haven't really been taking any medication or been following up or anything like that, right? A long-standing of untreated GERD can end up causing or leading Barrett's esophagus, okay? So what happens is, because of the reflux from the gastric contents, right, the reflux changes the cell lining in the lower esophagus area, right? Because you have those different layers within the body, and especially in the esophagus, you have those layers, and what happens is those layers are eroded, they're gone. So when that layer is gone, remember, your body is going to try to go through the process of mitosis to regenerate those cells. So in the process of mitosis and regenerating those cells, what happens, right? You always have the possibility of having cancer cells, because the reason why you have cancer is pretty much is mitosis gone crazy, right? Within that regeneration of the cell is not functioning the way of a normal cell would function, and it has an overgrowth of the mitosis, and they're not functioning cells, right? They're not functioning or carrying out the action of what the body is requiring them to do, all right? So anytime I have damage to a layer, right, the body is going to try to regenerate itself, and it regenerating itself, right, it causes the squamous cells, right, because you have they're more like box shape, right, like a squarish texture to them. And what happens is when that reflux keeps hitting and hitting and hitting that esophagus, right, it changes that layer within the cell from squamous, right, to a different type of pattern, which pretty much is destroying that layer, altering those cells. And when the body is trying to regenerate to make those cells back into this area, you have a precancerous cell, right? And when it's trying to initiate the healing process, like I said, it's trying to heal itself and go through the process of mitosis, it leads to a precursor of esophageal cancer. So sometimes your patients who are experiencing esophageal cancer may be because of the fact that they had Barrett's esophagus. Why? Because of a long-standing untreated GERD. Okay, so clinical manifestations that you're going to see, which is also my signs and symptoms and my nursing assessment, is going to be very similar to signs and symptoms of GERD, right? The main thing, though, that they're going to complain about is the heartburn, okay? But as far as signs and symptoms, they are going to be similar to GERD. Okay, so now we're going to have the diagnostic testing, right? So one of the things that you have is the EGD, which is esophageal gastroduodenoscopy, which pretty much is going to scope, right, or have a camera go down to the esophagus, the gastro area, and the duodenal area, which is also known as the small intestine. So the test name is actually within the name, all right? But for sure, it's called EGD, and what it's going to do is going to reveal the esophageal lining, right, and it's going to show whether it's red or it's pink. And of course, if the person is experiencing the Barrett's esophagus, it is going to be red rather than pink. Normal is pink. Red means that it's inflamed, it's irritated, it's eroding, there's problems, there are complications that's going on, okay? So you want to see a pink esophagus rather than a red esophagus. Then you have your biopsies, okay? And you have a biopsy, you have the high-grade dysplasia, which is also known as HDD. And what it's going to do is going to show evidence of the squamous cells. So remember, the esophagus area is supposed to have the squamous cells, right? Which the squamous cells look more boxy, like this, right? And instead, what it's going to show is going to be replaced by columnar, right? Epithelial type of cells, okay? That is going to resemble more of the stomach and intestines. So remember, if the stomach and the intestines have the more of the columnar shape cells, right, and then all of a sudden your esophagus is having those same shaped cells, that lets you know that the content that is in the esophagus is from the stomach and the intestines, and is starting to shape in that area, just like the stomach and the cells and the intestines. So a columnar will probably look more like this. All right, and the squamous will look more of an actual square. Okay, so you have square versus rectangular. Okay, so now my nurse interventions, right? What do I want to do? How can I help a person who has Barrett's esophagus? Okay, so first thing I want to do, I want to have a follow-up endoscopy within 6 months. You know, see if there's any minor changes within the cells. Okay. Also, you may have some treatments. Okay, and the treatments is you may have an extensive surveillance with a biopsy. Okay, you have endoscopic ablation therapy, right, which is your photodynamic therapy, and then you have your esophageal ectomy, which I will put the more information about these different treatments within the description box for you to read up on and to get more information for those of you guys who would like to know more information about it. But these are the treatments that they can do, but mainly is going to be observing and monitoring the changes of the cells. So if you can see the changes of the cells happen a lot more quickly, you can kind of prevent the cancer or the changing or the precursor for cancer from forming, right? So again, mainly monitoring, but then these are some procedures that you can do. So please check out the description box to view those items, okay? So I just want to say thank you again for watching. Please subscribe, like this video, put a thumbs up, comment in the section below. Don't be shy. If you have any questions, any concerns, please leave in the comment section below. And again, thank you for coming on this journey.